I just hold the piston like this.
All should focus how he is holding the piston. Where exactly you hold the piston is very important.
Yes,
part.
along the long axis of the shaft of the piston like this, and you have to make sure that the lower end of the piston is inside the fenestra and the upper end is around the long press of the incus. Yes, yes, yes.
Both should go in simultaneously.
Yes, sir. Because a few minor adjustments you can do once you place the piston.
Yeah.
I think the piston is a little short in this case, so I wasn't able to place it inside. It is just about reaching the tip of the fenestra.
So this is the most important step before we go in for crimping.
Sorry, sir?
I'm talking to the audience that
Yeah,
telling
yeah.
them that this is the most important step, how we
Yes,
put in
yes,
the piston.
yes. So you can see the lower end of the piston here. Ideally, there should be a little more length of about 0.25 millimeters more, so that it is completely inside the fenestra. Here it is just at the level of the fenestra, and in the upper end you can see the loop of the piston is around the long press of the incus. This piston seems a little thin here, so crimping might be a little difficult. Crimping is the most critical step. You have to go around the loop of the piston and gently close the mouth of the piston. In this, it is a little narrow.
Order is coming in between. It's a very difficult step.
Yes, yes, yes.
Step is apart from putting the piston in. Again, you have to have very good instrument and very safe hands.
I'm not very happy with the piston also because it is doesn't look very sturdy. It is a little loose and it's twisted a bit.
I think it's a crocodile. You don't have a proper crimper, is it?
I usually use a crocodile.
Do you routinely use the Teflon pistons or do you use
Teflon piston, sir.
With tungsten head with the laser?
Sir. No, only Teflon.
Because in that, in tungsten head, crimping is much easier with the laser. You just put two shots and
now
it crimps.
I got it. Now you can see slowly it is getting crimped. So you shouldn't apply too much pressure, and that is how slowly you can crimp the piston.
Yeah. Yeah.
And then you can do what is called the bend test and the lift test. So bend test, you bend the shaft of the piston and make sure it is not coming out. And as for the lift test, you slowly lift up the incus and again see the lower end to make sure that the piston is not coming out. So this is how you can do a stepidotomy. And at the end of the procedure, I take post-auricular soft tissue and place it around the fenestra just to seal the fenestra. Because the diameter of the piston is 0.4 millimeters, whereas the diameter of the fenestra which I have made is 0.6 millimeters. So to close the gap of 0.2 millimeters, I use a soft tissue. So that is how we do a stepidotomy. It is a very delicate procedure, but very rewarding procedure. Soft tissue we take post-auricularly. Loose areolar tissue is what we take. So just make a small incision there and take the soft tissue.
Hello.
Yes, sir.
Dr. Vinay, I'm Dr. Ashraf.
Yes, sir.
Professor from SS Medical College, Rima.
Yes,
I just wanted to know, do you use vein graft to seal?
No, sir. I have not used vein graft. This soft tissue is more than enough. Of course, there are many ways to seal it. Each surgeon has their own preferences. Vein graft, some people use fat, some people use blood clot also to
Yeah.
just seal it. But I'm comfortable with just soft tissue, sir.
Okay. Thank you.
So now I'll proceed to do a mastoidectomy. So this is a very important exercise, especially for the juniors. So cortical mastoidectomy, one should be very thorough, and to get the confidence to do it on a live patient, all of you should practice on a cadaver.
Sir, can you just
Fine.
show the anatomy, rather the surface anatomy and the landmarks?
Yeah.
Yeah, Doctor, we have one more thing. Just wanted to know any advantage of this differently microscope has got, but any experience of yours in endoscopic stapedectomy?
No, sir, I don't do endoscopic surgeries. So microscope I'm very comfortable because we can use both the hands. And since it is a delicate procedure, I prefer microscope definitely in stepedotomy, sir. So just to orient again, this is the right temporal bone. This is the mastoid tip here. So the mastoid tip will be near the foot end of the patient. This is the root of the zygoma. So this will be the head end of the patient. This is the mastoid cortex which I've exposed. And this is the linea temporalis. This is the posterior bony meatal wall. So I'll be drilling along the triangle of attack or the McEwen's triangle. So the first line along the linea temporalis, the second line along the posterior bony meatal wall, and a third line which is a tangential line joining the first two lines. So that is the safe area to drill. And this is the spine of Henle. Always try to open the antrum above the level, superior to the spine of Henle. So it is always safe to go superior to the spine of Henle because that reduces the chance of injury to the facial nerve. It is a highly cellular mastoid, as you can see here. When I drill, you can see so many cells opening up. So one has to be very careful because you can suddenly open up the antrum.
Yes, for the beginners, first identify the landmarks as the sir has explained, and then use the side of the burr for cutting.
Yes. So this is the first line here along the linea temporalis. The second line along the posterior bony meatal wall like this. And the third line, which is the tangential line, joining the first two lines. So very cellular mastoid, very good for demonstration. And whenever you're doing a cadaveric dissection, always try to explore the mastoid completely. Don't try to do a narrow mastoidectomy. So this is your opportunity to see where each and every structure is. So always do a wide cortical mastoidectomy. In fact, there are less chances of complications when you do a wide mastoidectomy rather than doing a narrow one. So go up to the mastoid tip here, and posteriorly you can go up to the, you can go posterior to the sigmoid sinus also. Your level can be up to the emissary vein, which comes much posteriorly. Fine.
Good, Dr. Vinay.
Yes,
I
sir.
can recall my time with Dr. Mahadevaya in Mangalore at Basangudi Center. I have worked with him for almost 3 weeks.
Yes, sir.
And that was the first time the language you are using, the tangent and everything. Even I learned the same way of otology from him.
Yes, yes.
So I have seen Dr. Mahadevaya working and for almost 3 weeks.
Sir.
He used to do Baha in those days. That is 2000, year 2000. He used to do Bahas
Sir.
that early. So
Sorry.
I had met your father as well, Dr. Vijayan.
Okay. Sir.
So it's good to see and recall those days.
Thank you, sir.
You were the doyen of otology.
Sorry, sir.
Dr. Mahadevaya was a doyen. He was one of the
Yes, sir, definitely. We are
leaders
all following his principles only.
yeah. Even we follow his principles. So, our homage to him. He was a nice person. Any landmarks you would like to tell the students here as you
So
go in?
So always stay superior to the spine of inlay in order to open the mastoid antrum. And once you open the antrum, you can see the lateral semicircular canal. So now you can see this is the lateral semicircular canal where I've kept the suction tip. So
Yeah.
this is the lateral semicircular canal. It is a very cellular mastoid, so I have a good space in the antrum.
Yeah.
You
Of
should
course, it's
keep
better to
the
switch over to a smaller burr tip, and for beginners, a diamond burr tip is also better. Give.
You should keep this mastoid cavity as wide as possible laterally, so that you get to see the mastoid cavity better
Yes,
and
yes, sir.
manipulate your instruments much better medially.
Yeah. The more narrow it is, the more chances of complications because you won't have enough space to work with. And in ENT, it is always a question of creating space. And here I have to be careful about the tegmen. Always look out for any change in sound and change in color. So that indicates that you are close to an important structure. For example, when you're close to the dura, you get a very high pitched tone, and also there is a change in color. You get almost a pinkish color in a live patient, and here you can see the bluish color here. So that indicates that I'm close to the dura. These may be the dural blood vessels here. So I should be careful and I should switch over to a diamond burr tip when I'm working here. And this is the sigmoid sinus here. Wash. And this is called the sinodural angle. This is the sinus, this is the dura, and this angle is the sinodural angle. So a lot of times we see cholesteatoma also in the sinodural angle, and when we are doing a canal wall down procedure, opening up the sinodural angle is one of the important principles that enables a good soft tissue collapse and helps in cavity obliteration also. So go as far posteriorly as possible, because some cases you do encounter cholesteatoma going posterior to the sigmoid sinus. So if you've had experience drilling out all these areas in a temporal bone, you'll be more confident to deal with it when you're dealing with a live surgery and you encounter any cholesteatoma going posteriorly. You'll know exactly how far you can go. These are all still cells. Very cellular mastoid. So you can see this is the sigmoid sinus shadow, and I've gone posterior to that also, and few cases we have seen cholesteatoma going here in all these cells also. So in such cases you have to do a wide mastoidectomy and try to clear out all the disease. Sometimes you also encounter granulations, extensive granulations, especially in case of tuberculosis. So even in such cases all these cells have to be explored.
Again, I'm saying the cellular mastoid in on a cholesteatoma patient is a difficult case rather than the sclerotic mastoid.
Yes, sir, very true. And in most of the congenital cholesteatomas, we see a cellular mastoid. So in these cases, it is very tricky. Now I'm drilling over the sigmoid sinus. I'm using a diamond burr tip. I can already see the blue shadow of the sigmoid sinus. So this is what I was saying. You should always keep an eye out on any change in color. You can very clearly make out that there is a bluish color change, and that is the sigmoid sinus, and also a change in tone. So it is a high pitched sound when you're working close to the sigmoid sinus, when the bone becomes thin. I don't know if you can hear the sound of the burr tip there.
No, that's not audible.
Okay.
For the juniors, this is one of the most important procedure of otology. You have to do a good mastectomy,
Sorry, sir.
whether it's cortical or modified radical. Even for some meninoplasties, tympanoplasty, you have to do a mastectomy first. Even for a cochlear implant, you have to do a mastectomy. Various approaches, you have to do a mastectomy. So, doing a good cortical mastectomy is a very important learning step for all otologists. So, I just want to emphasize, as Dr. Vinay is showing it very nicely. So, each and every step, each and every landmark, how you go about it, how you drill is very important so that you avoid complications, because it's a closed area and a small area. But with good microscopes and good drills, the complication rates have come down drastically. But it's very important to know all the landmarks, because this is the gateway to otology. Mastectomy surgery is a gateway to otology, because even if you do cochlear implants later on, or even head and neck surgeries related to ear, you have to know good mastectomy. You see how the mastoid looks like when it is drilled completely, where the elevations are, where the curves are, where is the sigmoid sinus, where is the dura. So you need to learn this. And Dr. Mahadevaya used to say that before doing mastectomy in a live patient, you should practice at least on 200 temporal bones. Although it's not possible nowadays, but yeah, that's the amount of time you should spend on doing mastectomies.
Yes, sir. I would say at least 10 bones now one has to do before trying to do it in a patient. So now you can see the lateral semicircular canal very clearly. So you can see the difference between the cells and the labyrinthine block here. So the mastoid air cells, you can see there are a lot of septations, and you can see the air cells very clearly. This is a very solid.
Dr. Vinay, it's a bit blurred now.
Yeah.
Picture. Can you focus a bit, please? Yeah, that's better. That's better. Much better.
Is the focus okay, sir, on the lateral semicircular canal?
No, it was a nice,
Okay.
but little bit of blurred vision is there. Can you focus a bit? Yeah, that's better. That's better.
Okay.
So
So this is the lateral semicircular canal here. So you can see it is a solid bone and a little more yellowish in color compared to the surrounding areas. And here I am getting the shadow of the superior semicircular canal also. There are few cells here. Once I drill that, you can see the superior semicircular canal. And here you can already see the incus and the malleus. And this is the attic here. And I wanted to show a good epitympanotomy. So this
can you show attic, zoom in the attic, because
yes, I'll drill a little bit more there, sir.
you can
So this
show the incus head of incus.
yes, sir. I'll drill a little bit more there and expose further. So this epitympanotomy is a very useful exercise. So it has many indications. Some of the indications are in cases of tympanosclerosis. There will be tympanosclerosis in the attic between the inguinal joint and the tegmen, and that will be fixing the oscular chain. So to make it mobile, one has to do a epitympanotomy, see the inguinal joint and remove the tympanosclerosis in the epitympanum. Second indication is in case of extensive granulations, especially in cases of tuberculosis. There will be granulations completely surrounding the epitympanum, and that will be leading to the conductive deafness, and even that can be tackled from this route. And sometimes we come across bony ankylosis of the malleus. So in bony ankylosis, there will be a thick shelf of bone attaching the malleus to the tegmen, and clinically it may look like otosclerosis, and when we open the when we elevate the tympanic membrane and we try to palpate, the stapes will be moving, but the malleus and incus will be fixed. So in such cases, we have to do an epitympanotomy and try to remove the bone which is fixing the malleus to the tegmen. So these are some of the indications of epitympanotomy. So to do an epitympanotomy, you can go up to the root of the zygoma. So there are no important structures here. Only keep an eye out on the tegmen on this side. And posterior canal wall.
Even sometimes in cases of mucosal disease, we find those fibrogranular tissues.
Yes, yes, sir.
Blocking the epitympanotomy, and we have to do this epitympanotomy to clean that.
Yes, whenever we don't get patency of the antrum, we can always do an epitympanotomy and explore what is there. So this gives a lot of clue. Many times there will be hidden disease in the epitympanum which will be causing restricted mobility of the ossicular chain. And in such cases, for good hearing results, this epitympanotomy is very crucial. So since this is a very cellular mastoid, the epitympanum easily came into view. Sometimes there is very little space between the tegmen and the ossicular chain. So in such cases, it becomes very difficult, and you have to use a contrangle handpiece in some cases to access this area. Now the beauty of this epitympanotomy is that it enables you to retain the normal ossicular chain. So as an otologist, your aim should be always to retain the normal ossicular chain. So when there is tympanosclerosis here, or granulations, or bony ankylosis, you can clear the disease by doing epitympanotomy without disturbing the normal ossicular chain. So to retain the normal ossicular chain, you have to be very careful not to drill the ossicular chain directly. The whole purpose of doing your procedure is to retain the normal ossicular chain, and when you're drilling, if your burr tip touches the ossicular chain, then it will be disastrous. So when you're going close to the ossicular chain, I'm going to switch over to a smaller burr tip.
Basically, you have to take precaution. You don't have to touch the medial epitympanum.
Yes, sir.
That's an important thing.
Yeah, so you can see I'm using a small burr tip here. This bone I have to drill without touching the incus or the malleus.
Yeah, one thing just to add upon, what should be the direction of the burr? That is very important for the genius.
Direction of the burr should be away from the ossicular chain, always away from any important structure. And also the speed you can control with the foot control. And even if your burr tip slips now, it is not going to go and hit the ossicular chain. Of course, you should be careful about the dura also, but in this case, since the tegmen is still intact, I can apply more pressure towards the tegmen.
And it should be parallel to the important structures.
Yes, yes, sir.
Well, for the beginners, even if you expose the dura, you should not be worried. Rather, avoid the ossicular chain and the medial wall.
Yes, sir. Ossicular chain, if you hit, there may be chances of subluxation of the stapes, which may lead to sensory neural deafness. And of course, like I said, the whole purpose of doing this procedure is to retain the normal ossicular chain. So that will be a failure. So you have to be very careful.
And medial to the ossicular chain or this body of the incus, you'll be finding the facial nerve. So that's why you should always avoid the medial wall of the epitympanum while drilling, while doing epitympanotomy. You can drill superiorly, you can drill inferiorly on the posterior superior canal wall or towards the tegmen, but never on the medial wall of the epitympanum.
Yes, sir. And also the speed, you have to be slow and steady. Cog, yes. The cog comes here. So the cog is a bony projection which divides the attic into anterior and posterior attic space. So this is how, this is almost mimicking a bony ankylosis which I was talking about. So in bony ankylosis, there will be a bone fixing the malleus to the tegmen. In this there is a little space, But in case of bony ankylosis, it will be completely fixed and there will be no movement of the malleus. So in such cases, we can do an epitympanotomy and break the bone here and try to create more space so that the ossicular chain becomes freely mobile. Now you can see there's hardly any space, so I'll just show you how we can create space. Saline, slow, slow, slow. So I'm working in a very close distance to the close proximity to the ossicular chain without touching it. In these cases, you can also use a contra-angle handpiece that gives you a good working space.
Working space as well as the vision is also improved.
Sir. Slow, very slow, drop by drop. Wash. Wash, wash, wash. Saline. Saline. Small one. Small suction. So I'm making space between the malleus and the tegmen. I can drill this bone a little bit more to expose more of the malleus head. Wash. And now you can see the malleus also completely.
Please.
Nicely done dissection, I would say. And
Thank you, sir. Yeah.
do you do this often posterior tympanotomy?
Posterior tympanotomy, sir. For we do posterior tympanotomy. We do for face nerve decompression. Can do a posterior tympanotomy to find the nerve. I don't do cochlear implants, so not much of posterior tympanotomy for cochlear implants. Sir.
Will you be demonstrating?
Sorry, sir.
Will you be demonstrating posterior tympanotomy?
Yeah. I'll be demonstrating. So here you can see a few mucosal folds. So now you see there's much more space here. I can even drill out this little bit of bone to create more space. It's not needed, but just for demonstration purpose. Slow. Again, if you do this regularly on a cadaver, you get more confidence when you face the situation in a live patient. So you can confidently drill here along the epitympanum, around the ossicular chain, and create space like this. And in case the ossicular chain is fixed, you can make it freely mobile. So that is the advantage of doing an epitympanotomy, and it is a very useful exercise. And I urge all the juniors to start practicing it. Now you can see the anatomy of the ossicular chain very clearly. This is the head of the malleus, this is the body of the incus, This is the short process of the incus getting attached near the fossa incudis. This is the piston which I've placed, which is seen here.
Very nicely shown. And
And
if you know to do epitympanotomy, sometimes you don't even need to do a canal wall down technique. You can clear the
yes, sir.
stoma.
Sometimes
And
if cholesteatoma sac is confined to the epitympanum, epitympanotomy can be done and pushed from the epitympanum into the middle ear and can be removed in toto. Same with attic retraction pockets also. So many indications are there for this procedure.
so if nowadays if you are able to save the posterior canal wall, that's a boon for the patient for future.
Yes, sir. So this is the lateral semicircular canal here again, and here you can see the horizontal facial canal. This is the horizontal facial canal, this is the lateral semicircular canal, this is the short process of the incus. So now I'll drill out the mastoid a bit further and then proceed to do facial nerve decompression, transmastoid through posterior tympanotomy approach.
Yeah.
So before doing facial nerve decompression, you have to thin out the posterobony meatal wall completely and also expose the mastoid widely. So I've done a wide cortical mastoidectomy, but I'll still drill a little bit more of bone just to make it easier for me. I'm thinning out the posterobony meatal wall. These are all air cells. You can drill out very comfortably.
Thinning of the posterior canal wall is very important in the exposure of facial nerve till the digastric ridge.
Yes, sir. It should be completely thin, so it becomes easier for you to identify the nerve. So now I'm going close to the digastric ridge. Once we identify the digastric ridge, it is very easy to delineate the facial nerve. But sometimes the digastric ridge may not be very prominent. So in such cases, you can go up to the digastric muscle, find the digastric tendon, and once you follow the digastric tendon, that will lead you directly to the vertical segment of the facial nerve. Yeah.
You have to focus on the anteromedial wall of the mastoid tip so as to
Yes,
find the digastric ridge.
I'm going close to the mastoid tip here. This is the digastric ridge here. You can see this prominent ridge. This is the digastric ridge. And if you follow the ridge, that will lead you to the facial nerve. This is a very good landmark and a consistent landmark to find the vertical segment of the facial nerve. Yes. One minute. Is it focused on the digastric ridge, sir?
Yeah, it's focused.
It's focused, okay. So even if you don't find the digastric ridge, sometimes you might accidentally drill it out, or sometimes it may not be very prominent. You can continue drilling in this direction till you find the digastric tendon. So I'll just show you that also. This is the digastric ridge, and you actually have to follow the digastric ridge to find the facial nerve. Even if you don't find the digastric ridge, if you keep drilling, you find the digastric muscle. Can you see the soft tissue here? That is the digastric muscle. And you continue tracing the muscle, it will lead you to the digastric tendon. This is the digastric tendon. Little more I can drill. Yeah, this is the digastric tendon. And you follow the shadow, that will blend into the facial nerve. So this is the easiest way to delineate the vertical segment of the facial nerve. This is a very big bird tip I'm using, so I'll change. So before that, I'll just drill out a little bit more bone.
For the beginners, these are very important landmarks, and you can find these landmarks only if you remove the cortex nicely. You have to have a big mastoid cavity, saucerized cavity. Saucerized means the margins have to be slanting, and only then you can you can see all these landmarks nicely. Because if you do work in a hole or in a narrow cavity, you will miss things and you can injure vital structures. So it's very important to have a very wide mastoid cavity, even for the cortical one. You need to practice that in all cases. Am I right, Dr. Vene?
Yes, yes, sir. Yes, sir. Is the focus okay, sir?
A bit more medially, sir. Now it's fine.
Now it's okay. Is it focused here on the digastric tendon? Okay.
Yes, focus, sir.
Okay. So now I switched over to a diamond burr tip. And like I said, just follow the shadow of the digastric tendon. That will directly lead you to the facial nerve. So there's a very easy way to identify the facial nerve. There's two ways to identify the facial nerve. One is the posterior tympanotomy approach, which I'll be showing, and the other is just follow the digastric tendon.
Here you can also appreciate the advantage of good irrigation.
Yes, sir, yes.
Unless you have got a good irrigation, adequate irrigation, you won't be able to appreciate the structures which are coming.
And also, after every stroke, I'm lifting up the burr tip just to make sure that the facial nerve hasn't come into view still. So your direction of your burr tip, the speed of the instrument, everything counts. Still thinning out the posterior wall a little bit more. Saline.
So you are going to do a posterior tympanotomy now, is it?
Yes, sir, yes, sir. I'll just show you how to delineate the nerve from distal to proximal.
Right.
That is from the digastric muscle side, and also I'll show how to come from proximal to distal. This is the shadow of the nerve here, which I'm seeing medially. That is the shadow of the nerve.
Can you just adjust the focus a bit? It's little
Yeah.
blurred. Yeah.
Is it okay, sir?
Yeah, now it's sharp, yeah. So can you just recapitulate the landmarks which you
Yeah,
have told?
So first I identify the digastric ridge. So if you
Yeah.
identify the digastric ridge, it will come up till here and you can find the facial nerve easily. So many times we don't find the digastric ridge, or sometimes you may accidentally drill it out, especially as beginners. So in such cases you can go more deep. You'll find the digastric muscle here. So the only problem if you drill the digastric muscle is there'll be a bit of bleeding, and that might take a little time to stop. But that is not a problem. It will stop with this thing. You can cauterize it, and if you follow the muscle, it will lead you to the the digastric tendon. So this is the digastric tendon here, and if you keep following the digastric tendon, that will blend into the nerve like this. So this is the beginning of the vertical segment. This is the distal vertical segment here, the shadow. So I'll completely delineate it further. So for that I'll come from posterior tympanotomy also. So I'll show both the approaches and how it can be delineated from both the sides. So for posterior tympanotomy, again you have to completely thin out the posterior bony meatal wall. It should become almost papery thin. Burr size depends on where we're drilling, but to open the posterior tympanotomy, this thing, with the facial recess cell, we can use a 0.6 millimeter cutting burr.
Just tell them what precaution you need to take while drilling here, because some beginners might go directly into the nerve.
Yes, yes, sir. So just thin it out. I'm not completely drilling it still. I'm just drilling out the posterior bony meatal wall to make it thin. Yeah, direction should be parallel to the direction of the facial nerve. So you can see I'm drilling parallel to where I'm expecting the facial nerve. So it's always safe when you're drilling parallel.
So the beginners, you have to know where exactly the incus is. The facial nerve is below the incus, right? And you have to drill everything with a diamond burr here and under vision. Nothing has to be blind.
Yes.
Very. And if you see the incus, you can see the incus, and you can just have an idea of where exactly the facial nerve is going. A rough idea in your mind, what is the direction of facial nerve and where exactly it is going. Because the incus sits on the facial nerve. So you have to be just above it.
Yeah, the incus short process is a very useful landmark.
Yeah, yeah. So that's why it is recommended that you do more and more temporal bone workshops and hands-on, so that you get a mental picture of where you are drilling.
So after you thin it out like this completely, you can open up the facial recess cell. So the facial recess cell is just a small cell which is located about 1 millimeter inferior to the incus buttress. Incus buttress is where the fossa or the fossa incudis or the incus buttress is where the short cross of the incus is attached. So I'll just take a small diamond burr, and you can just open up this cell here about 1 millimeter inferior to the attachment of the short cross of the incus. This is the attachment of the short cross of the incus. This will be the area of the facial recess cell. So slowly drilling it out, and you can see it opened up. So this is the facial recess cell, and this is a very useful exercise. The facial recess, cell landmark is very useful. This is also called a posterior tympanotomy. So posterior tympanotomy has a lot of indications. To do a facial nerve decompression like this, you can always do a posterior tympanotomy, and also cochlear implantation, you have to do a posterior tympanotomy. And there is
Very
also something called the extended facial recess approach, where
Yeah.
you delineate the chorda tympani and where you cut the chorda tympani and go along the origin of the chorda tympani to get a wider exposure. So that has been described for removal of glomus tumors, small glomus tumors. But somehow I don't think that gives enough exposure to completely remove glomus tumors.
Very
So
nicely
to-
done, Dr. Vinay.
Thank you,
And
sir.
the audience should be really impressed how you have shown it. There is applause here just to
Thank you.
make it.
Thank you, sir. So through the posterior tympanotomy, usually you will be able to see the stapes and the incudostapedial joint. In this case, I've already removed the smaller one, small suction. In this case, I've already removed the stapes. So I'll just show you what all we can see from here.
As cochlear implants become more common, this is going to be a very important step for everybody to learn.
Yes, sir, yes. You can see the chorda tympani here. The chorda is usually the lateral border of the facial recess.
Facial recess.
Yes.
These are the questions one is asked in ENT vivas during the MS examination.
Yes, yes.
These are very set questions. So most of the students, registrars are aware of that. Lateral boundary of the facial recess, superior boundary of the facial recess. So now you can see for the students, you can see exactly how the facial recess is. Out of facial angle here.
I'll just drill out a little bit more.
This facial recess has got various names. As you know that the medial part is the facial nerve and the lateral part is the cardotympani nerve. So you call it cardofacial angle. If you read older textbooks, Robb, Smith and all, they have described it as a antrum threshold angle. They have given a term like antrum threshold angle.
Yes, sir. Sorry, sir, antrum?
Antrum threshold angle.
Okay, okay.
Antrum threshold angle.
Okay, sir.
They
Wash.
gave it.
Wash.
Posterior tympanotomy, facial recess approach, cardofacial angle, antrum threshold angle. So all these things are various synonyms which are used for this facial recess. So you should be aware of this. Thank you.
It is an important question also which appears in most of the exams. Boundaries of facial recess. So now I'm going medially. So the medial border of the facial recess will be the facial nerve. So I have to be careful here. I'm drilling along the direction of where I'm expecting the facial nerve. Keep an eye out for any change in color. Yeah, in live patients, there'll be bleeding also when you're close to the facial nerve. Bigger one. Of course, the chorda will usually be fixed in the bone here laterally, because I've already done a stepidotomy and I've tried to lift up the chorda. It is hanging loosely. Otherwise, it will be running along the bone like this here.
Yeah, I think you can see the impression of that.
Yes.
If
Wash.
Once you thin the posterior canal wall, then you can see the impression of the cardiac tympani
Yes,
nerve.
yes, sir. Here it will come.
Facial nerve.
You can see I've still not got the shadow of the facial nerve. It is quite deep. So when you're looking for the facial nerve, it is difficult to find, but when you're not looking for it, you easily get it. Slow, slow. So now you can very clearly see the incus, and that is where the stapes would have been, the incudostepedial joint. In fact, while doing a facial nerve decompression, we can go through the facial recess approach to disarticulate the incudostepedial joint and remove the incus. To decompress the horizontal segment of the facial nerve, you have to remove the incus to reach the horizontal segment and the geniculate ganglion, and also the beginning of the labyrinthine segment. So in such cases, you can pass a 45-degree pick through this facial recess cell and disarticulate the incudostepedial joint and remove the incus. So one of the disadvantages of doing this transmastoid facial nerve decompression is that you may have to remove the incus, and of course you have to do a primary oscular reconstruction at the end of the procedure.
When he is extending it inferiorly, you can see the structures more clearly. Then you can see the round window niche inferiorly. It will come in picture.
Yes, sir, yes. Yeah.
I think is close to the facial nerve, probably this area.
Now I'm getting the shadow of the facial nerve here.
And this one. There is some change in color.
Yes.
You can see the color is changing.
And I'm working parallel to the facial nerve, as you can see here. Saline?
Hello.
Yes, sir. Saline? Suction tip.
Vinay, can you show us the carda?
Yes, yes, sir. Yes, sir. Just 1 minute. So now you can see the boundaries of the facial recess very clearly. Laterally, it is bound by the chorda tympani. This is the lateral border, chorda tympani. Medially, the facial nerve here, almost close to the second genu of the facial nerve. And superiorly, the fossa incudis or the incus buttress, where the short process of the incus is getting attached here. So these are the boundaries of the facial recess. Superiorly, fossa incudis, laterally, chorda tympani, and medially, the facial nerve. I hope it is clear to the juniors. It is a very important anatomy to know. And of course, if you keep tracing it here, you will reach the chordofacial angle where the chorda takes the origin from the facial nerve. So in an extended facial recess approach, you have to go all the way up to the chordofacial angle. You can cut the chorda tympani and get access to the middle ear. Now I'll take a slightly bigger burr tip and delineate the rest of the vertical segment. So I just wanted to show both the ways of delineating the vertical segment. One is through the posterior tympanotomy approach like I showed now. You can find the facial nerve on the medial aspect of the facial recess. The other one is the easier approach, which is by tracing the facial nerve from the digastric ridge. So both these approaches can be used to delineate the vertical segment of the facial nerve. For beginners, I feel the digastric ridge is easier to identify. So you can trace the nerve from distal to proximal. When you come from the posterior recess approach, you trace the nerve from proximal to distal. Big one. I'm used to a bigger one, so I'm just trying to.
See, where he is working is that is the area of retrofacial cells. Medial to the facial canal, you find retrofacial cells.
Here, actually, I can see the facial nerve shadow now.
Yeah.
Show you. This is the facial nerve shadow.
Yeah, this one.
More white. Here you can see. This is the facial nerve shadow. So I'll just try to delineate it a bit more. And also what you're seeing here, this is the chorda tympani. So if you can trace the chorda from here, you can see the chorda is going all the way along here, and here it is attaching to the facial nerve. This is the facial nerve coming like this. Chorda tympani is taking origin here and going all the way into the facial recess. Is it clear, sir?
Yeah, the anatomy of origin of the chorda tympani nerve is very much variable.
Yes, sir. But usually it comes in the distal vertical segment.
Yeah.
So now
Good.
I'm not applying any pressure, very gently drilling it because I know I'm close to the facial nerve.
Once you identify the facial nerve fully, and if you go medial to the facial nerve, then you can see the sinus tympani area. This is one of the approaches to sinus tympani.
Yes.
It's supposed to be a blind area in the middle ear, which you cannot see. So this is one of the approaches which have been described for removing cholesteatoma from the sinus tympani under vision. that is medial to the facial canal, you can enter.
Yes, sir. These are all still air cells here.
Yeah, tip cells
Tip
are.
cells, yes.
See, the mastoid hair cells are named according to the place where they are situated.
So now I can see the shadow of the nerve gently drilling without applying pressure.
Slightly brownish in color, which he is getting. This one. This area.
Wash. So this is how you have to slowly trace the facial nerve. Work parallel to the nerve, don't apply any sort of pressure. And now we can go almost up to the stylomastoid foramen here. These are all tip cells.
So when you are clearing the tip cells, you have to be careful that you don't damage the facial nerve, the lower portion of the vertical portion of the facial nerve.
Yes, sir. Because when you're drilling here, the other end of your bird tip might be accidentally drilling the facial nerve, so you have to be very careful. And I think this is the shadow of the jugular bulb here.
Yes,
This
yes,
is
yes,
the
this
shadow of
one.
the jugular bulb. You can see it is in continuation with the sigmoid sinus. Sigmoid sinus goes like this, and you can see the bulge of the jugular bulb. So I'll just drill a little bit more here.
So you can see this, it's like this.
Sorry, sir?
I'm just telling about the facial nerve,
Ha, ha, ha.
that they can now distinctly see
Yes,
the
yes, yes.
course of that nerve.
Yes. So now I'll remove the incus and go towards the horizontal segment.
Yeah, yeah. Now, can you focus it and
Yeah,
just and show that is it exposed now? Facial nerve?
Yeah, now I exposed it,
Yeah.
but the sheath is still intact. The epineurium is still intact.
Okay, okay.
So you can see the anatomy of the incus also. This is the lenticular process. Long process of the incus here, short process of the incus, and the body of the incus here. And this is the facet for the